Yeah, good evening, everybody. Lovely to be back after a little prolonged period, but it's great to see all of you. What we have this evening is something which is very common. All of you would have been exposed to it. You have your own experience to share, but we shall be taking into a different domain. However, before that, I wish to share some thoughts with you, my younger friends, is that there is information, there is knowledge, and there is wisdom. Information is there, accessible to anybody on earth. There's Google, libraries, journals, and then you invite that information. That becomes knowledge. And most importantly, to know how to use that knowledge is to have wisdom. So there are three distinct things: information, knowledge, and wisdom. So we are probably in the stage of, definitely in the stage of knowledge, but we are trying to get to wisdom now. So to know is not to be wise. To know how to use knowledge is to have wisdom. Knowledge speaks, but wisdom listens. We have very eminent panelists here this evening, experts. So they will be sharing information, knowledge with you from quoting various sources like journals, guidelines. But remember, if it only appeals to your logic and reason, should you apply it? Because guidelines are 3 years down the road. Today's experience becomes tomorrow's guidelines. So here we are, cutting edge technology, cutting edge knowledge for you to imbibe and then to apply is all up to you. So today we have malignant pleural effusion, for which a brief overview will be shared with us, spoken to, or maybe we can listen to, Dr. Syed Mudasir Qadri, young man. I've met him when I went to Kashmir for BronchoCon. At that time, I didn't know he would blossom and flourish into this budding, dynamic pulmonologist. So happy to see you where you are today, Dr. Qadri.
Thank you, sir.
He works in Sher-e-Kashmir. He's associate professor. For a young man like him, he has many publications, and he has an old head on young shoulders. So over to you, Dr. Qadri, to run us through malignant pleural effusions.
Respected seniors and my dear colleagues, I'm Dr. Syed Mudasir Qadri, Associate Professor, Internal and Pulmonary Medicine, SKIMS, Saura, JNK. Today I'll be discussing malignant pleural effusions. The objectives of my talk would be to discuss the basics of pleural anatomy, pleural fluid, and pleural effusion, to describe the pathophysiology of malignant pleural effusions, review the evaluation of a pleural effusion and malignant pleural effusion, and to summarize the treatment options for MPEs. The structure of pleura is essential to respiration, providing the lungs with lubrication and cushioning needed to inhale and exhale. The intrapleural space contains roughly 5 cubic centimeters of pleural fluid, which helps as a lubricant and decreases the friction between the two surfaces, especially during inhalation and exhalation. It also acts as an adhesive and helps in expansion of the lungs. This delicate balance of fluid is maintained by the oncotic and hydrostatic pressures and the lymphatic drainage. And if there's any disturbance in these systems, it can lead to pleural effusion. Now, coming to the anatomy and physiology of pleural fluid balance. So this is an anatomical depiction of lungs surrounded by the visceral pleura, surrounded by the parietal pleura, and the chest wall. So we can see the cavity between the visceral and the parietal pleura. This is a pleural cavity. And if there is accumulation of fluid, it is called pleural effusion. Now here we see 3 spaces. This is the visceral space, this is the pleural space, this is the parietal space. So the difference between the hydrostatic pressures across the 2 sides and oncotic pressures across the two sides is going to decide the pleural fluid. So there is a net negative hydrostatic pressure in the pleural cavity, It's because of the tension, surface tension of the alveoli, elasticity of the chest wall, elasticity of the lungs, which helps to keep the lungs expanded. Then there is more hydrostatic pressure on the parietal wall side, 30 centimeters of water, then on the vessel side, 24 centimeters of water. So there's a net shift of fluid from the parietal wall towards the pleural cavity. Whereas the oncotic pressures are same on both sides, 29 centimeters of water. So once pleural fluid is formed, it is reabsorbed back through the lymphatics, and lymphatics are present only on the parietal pleura. So parietal pleura is the most important membrane in maintaining the homeostasis of pleural fluid. So pleural effusion is the accumulation of fluid in between the parietal and the visceral pleura called the pleural cavity. It can occur by itself or can be the result of surrounding parenchymal disease like infection, malignancy, or inflammatory conditions. Pleural effusion is a frequent complication of advanced malignancy accompanied by the morbidity and mortality. So how do we differentiate between malignant and paramalignant effusion? The main point of a malignant pleural effusion is the presence of M cells or malignant cells in the pleural fluid or the pleural tissue obtained by percutaneous biopsy or thoracoscopy or even at autopsy. Whereas malignant pleural effusions are pleural effusions found in patients without direct involvement of the pleura, or there are no M cells in the pleural fluid. For example, a patient of malignancy has CHF, a patient of malignancy has malnutrition, cachexia, hypervinemia leading to pleural effusion, etc., etc. Now coming to malignant pleural effusions. So they are the leading cause of exudative pleural effusions after paramalignant effusions. They account for 22% of all pleural effusions and 42% of exudate effusions. The prognosis of MPs is not that good. It ranges from 3 to 12 months. That is why our main aim is palliative rather than curative, and we aim at improving the quality of life of these patients. Malignant pleural effusions develop as a direct extension of cancer into the pleural space, or they are due to the inflammation induced by the malignancy. They're most commonly secondary to lung cancer, especially adenocarcinoma type, as it has predilection to invade the pleural membranes. The second most common is breast cancer. And getting them together, lung cancer and breast cancer account for more than half of the cases of malignant pleural effusions. The third most common cause is lymphomas, Hodgkin's and non-Hodgkin lymphoma. But in young patients, this may be the commonest cause of malignant pleural effusions. Whatsoever we do, in around 5 to 10% of patients, malignant effusions remain undiagnosed, unidentified. So the pathophysiology mainly results from two mechanisms. The entry rate of liquid into the pleural space must increase, and the exit rate must decrease through the parietal pleura. Increased entry of the liquid into the pleural space may be the result of increased filtration across systemic or pulmonary capillaries, and this comes under indirect causes of MP. While decreased exit of fluid from the pleural space that mainly occurs to parietal pleura can be blocked because of lymphatic blockade, and this comes under the direct causes of malignant pleural effusion. Malignant pleural effusion may be the first presentation of a malignancy. Dyspnea is the commonest presenting complaint in more than half of the cases. This results from the alteration of respiratory mechanics in which the diaphragm is displaced caudally and the chest wall is displaced outward. A cough may also be present due to the distortion of lung. Chest pain due to involvement of sensory neurons, mainly on the parietal and occasionally on the visceral pleura, can also occur. For the physical examination, the main findings are decreased breath sounds, dull percussion note, and decreased tactile ocriformitis. But the point is that the development of pleural effusion should have no bearing on oxygenation, as it does not alter VQ dynamics or result in shunting. If a patient with MPE has significant hypoxia, an alternative explanation such as pneumonia, atelectasis, or endobronchial lesion or pulmonary embolism has to be sought. So coming to the evaluation, First of all, any patient who comes with dyspnea should undergo chest radiography. Patients with malignant effusion present with moderate to large effusions with volumes ranging from 500 to 2,000 ml. 10% of patients present with massive effusions occupying entire hemithorax. A large pleural effusion should result in a contralateral mediastinal shift. If there is no shift, then think of endobronchial lesion. Then think of involvement of pleural surfaces or even fixation of the mediastinum. Coming to thoracic ultrasound, chest ultrasonography has 100% sensitivity in diagnosis of pleural effusion. Although early pleural thickening in malignant effusions may be difficult to assess by ultrasound, but diaphragmatic thickening of more than 0.7, parietal pleural thickening of more than 1 centimeter, and detection of visceral or parietal nodules on ultrasound are highly suggestive of malignancy and such malignant pleural effusions. This can also be used for appropriate site, looking for site for thoracentesis. CT scan of the chest is the best modality for visualizing pleural surfaces in detail, along with the lung parenchyma, chest wall, and mediastina. On CT, pleural thickening greater than 1 centimeter, irregularity of the pleural surface, pleural space, and pleural nodules can indicate malignant effusions, but approximately 50% of patients with MPE have no pleural abnormalities on CT. That means they have M cells present, but the pleural abnormalities are not there. The presence of pleural septations and occultations is easily appreciated by ultrasound better than CT and may help in guiding the therapeutic pleural interventions. As we know, we may do different intervention in a septal pleural effusion with septations and a pleural effusion with free fluid. So here's an example, a patient who has a malignant pleural effusion. We can see these septations on ultrasound. The same patient, while we did a CT, the septations were not nicely appreciable. So PET-CT scanning, it remains controversial in routine. So we don't diagnose MPE by PET-CT. There are a lot of false positive, like inflammatory pleuritis, rheumatoid arthritis, or even talc pleural disease may give a false positive diagnosis. False negatives can be seen in malignant mesothelioma or an indolent pleural malignancy. MRI in pleural diseases has been comparatively less studied, and the optimal protocol for MRI scanning has not been defined yet. Still, diffusion-weighted imaging has been particularly useful in diagnosing malignant pleural mesothelioma. Now coming to thoracentesis. Diagnostic thoracentesis, free pleural fluid that measures more than 10 centimeter on chest X-ray, ultrasound, or CT is an indication for diagnostic thoracentesis. Therapeutic thoracentesis should be performed in all symptomatic patients with suspected MPE to see whether the dyspnea is relieved or not, and to look for the recurrence or reaccumulation. If dyspnea is not improved with thoracentesis, an alternative diagnosis has to be sought, such as PTE, atelectasis, or lymphatic carcinomatosis. The gross appearance of malignant effusion varies. Most commonly, it's one of the common causes of blood effusions, but it may vary from absolutely clear to a cloudy appearance to even bloody appearance. So once we take the fluid out, so what is it? Is it transitive or exudative? So we have age-old Light's criteria. We all know it. So pleural fluid is considered an exudative effusion if at least one of the criteria are met. Pleural fluid protein, serum protein ratio more than 0.5. Pleural fluid LDH versus serum LDH ratio of more than 0.6. And pleural fluid LDH is more than 2/3 of the upper limits of normal lab value of serum LDH. These criteria have almost 100% sensitivity for diagnosing exudates, but for transudates, they may end up diagnosing 25% of cases wrongly as exudates. The pleural fluid for malignant effusions is almost always exudate, but not always. Rarely, malignant effusions can be transudative, but this is usually related to an underlying other condition simultaneously, causing increased hydrostatic pressure resulting in effusions, such as CHF. A patient has MCLs in the pleural fluid, has CHF also, can have a transitive effusion. Superior obstruction, airway obstruction with resultant atelectasis or pneumonia, and low oncotic pressure from underlying malnutrition or cachexia. Typically, demonstrating lymphocyte predominant fluid, although eosinophilic and neutrophilic predominant effusions do not exclude effusion secondary to malignancy. Definitive diagnosis requires demonstration of malignant cells on cytology sample obtained during thoracosynthesis. Cytologic yield does not depend on size, but the diagnostic yield varies with the type of tumor and the extent of tumor involvement of the pleural surface. So one, the type of tumor and the extent of the tumor involvement of the pleural surface may give us positive results. For example, cytology results are more commonly positive in adeno-CA than in squamous CA, as it has greater tendency to invade the pleural space. Remember, the first thoracosynthesis is expected to give a result diagnosis of approximately 60 to 65% of the times. One study has demonstrated that an additional thoracosynthesis gives a yield of another 27%. And on the third time, only 5% are added. So, as a dictum, if two thoracosyntheses have not yielded cytology and still an MP is highly suspected, the indication of thoracoscopy as an extra becomes very strong. The diagnostic yield of medical thoracoscopy is considerably higher at 95%, but it is far, far more invasive than simple thoracosynthesis. Finally, during thoracosynthesis, we can also do pleural manometry to identify trapped lung physiology. But pleural manometry, it's a different topic. I think we'll discuss it during the panel discussion. So malignant pleural effusions and the trapped lung. A trapped lung is defined as the inability of the lung to expand fully due to the fibrous visceral peel, which can be due to the endobronchial tumor occlusion and the collapse of the lung, or complete infiltration of the pleura by the malignancy. This may be more evident on imaging in those with large effusions without accompanying contralateral medicinal shift. So the patient has a large effusion, but no medicinal shift. So that means there's a probability there's a pleural involvement or there is an endobronchial tumor, endobronchial occlusion. In the physiology of the pleural effusion, pleural pressure is a positive. However, pleural pressure in the trapped lung is negative initially and drops steeply once the fluid is removed. Patients with trapped lung are unlikely to benefit from pleural disease because their surfaces are not going to oppose. So they're not the primary candidates for pleural disease. So let's go for evaluation summary. So there's a patient who is suspected to have malignant pleural effusion. We go for ultrasound guided thoracosynthesis. We make the diagnosis. Once the diagnosis is made, we go for the treatment options. If the diagnosis is not made, we can repeat the thoracosynthesis and make the diagnosis and go for the treatment options. Or we can go for image-guided pleural biopsy and make the diagnosis and go for the treatment options. If repeat thoracosynthesis is failed or image-guided biopsy is failed, we can go for medical thoracoscopy, which has a high yield of positivity, and then get the diagnosis and go for management options. So coming to management, the goal of management of an MP is not curative, it is palliative, and we want to improve the quality of life of the patient. If the patient is asymptomatic, we just observe. We don't go for draining the fluid, especially if the patient he's on chemotherapy and he has a chemosensitive malignancy. However, many patients present with significantly disabling dyspnea. Treatment should aim to relieve dyspnea, minimize discomfort, and limit their recurrent hospitalizations. Several therapeutic approaches depend on the following factors. These are the factors that tell us which route to follow. Number one, what is the clinical status of the patient? Number two, the ability of the lungs to fully expand or not. Number three, the availability of the approaches like thoracoscopy, etc., etc. So the first thing is serial thoracocentesis. Serial thoracocentesis can be performed for long-term management with the removal of no more than 1.5 liters at a time due to the risk of re-expansion pulmonary edema. But this is a reasonable option for patients who have poor prognosis, maybe less than 1 month. For those whose survival is more, then this is not the right choice to go with. In those who are expected to live longer, this may not be the practical treatment option. Furthermore, repeated thoracocentesis may result in adhesions between parietal and visceral pleura and can limit future thoracoscopic interventions, especially in those patients who have a longer survival rate. Now, what about pleurodesis and pleural catheter? Pleurodesis is a technique to allow for the position of the parietal and the visceral pleura to prevent reaccumulation of pleural effusion. It depends on whether the patient has trapped lung or not. If the patient has a trapped lung physiology, they are unlikely to be benefited from pleurodesis techniques, as the thick fibrous peel surrounding the visceral pleura would prevent the apposition of the two parietal and visceral surfaces. Patients with a malignant diffusion and trapped lung physiology are benefited by placement of indwelling pleural catheters rather than pleurodesis. A pleural catheter allows ambulatory drainage of pleural fluid daily for the relief of symptoms. Several catheters have been developed for this purpose, and studies have shown promising results regarding symptom relief and decreased hospitalizations in MPs. Spontaneous pleurodesis has been reported in some patients. The presence of the catheter in the pleural space, it stimulates an inflammatory reaction that encourages obliteration of the pleural space. So ultimately, this catheter is also helping us in pleurodesis. So tunneled pleural catheter is a silicone tube placed into the pleural cavity and tunneled subcutaneously with a small cuff. This allows the patients to easily drain the pleural fluid at home or at an outpatient setting. It is proven to be a relatively safe procedure that improves the quality of life. TPC is an alternative to pleurodesis for the treatment of frequent MPE, and there are advantages of TPE, like there's a clinically significant improvement in dyspnea. Placement can be done in the outdoor setting. Patient need not to be admitted, and patient can take the care of this catheter himself. There is a self-care at home. It can be done. And we have seen spontaneous pleurodesis is expected to occur in approximately 50% of these patients, and this usually occurs at the end of 2 months. TPC is successfully used in patients with trapped lungs, and in comparison with the pleurodesis, it causes lesser infections. Very, very important in these patients. They come with infections again and again, and TPC has an advantage on that. It was found that definitive procedure of insertion of TPC or pleurodesis compared to repeated thoracocentesis is associated with a lower number of subsequent procedures and complications. Chemical pleurodesis is another important mode of treatment. Chemical pleurodesis should be pursued with sclerosants. This can be achieved with placement of chest tube with installation of talc slurry, which is the most effective of the available sclerosants. Talc is thought to incite an inflammatory reaction in the pleural space that leads to fibrin formation and apposition of the pleural, parietal and the visceral pleura. Tetracyclines, bleomycin, and strong other alternative sclerosants, even betadine can be used. If the above procedures fail, pleuroperitoneal shunt or pleurectomy can be done, but they have a significant cost and morbidity. Now, another option is mechanical pleurodesis. Mechanical pleurodesis achieves the same result as chemical pleurodesis. However, it has been reported that it's more effective and secure method in comparison to chemical pleurodesis. Also, it is reported to be more effective in relieving symptoms and providing a better quality of life for patients, especially those with MP due to breast cancer with a pH of less than 7.3. So here's the flow chart of the treatment of these patients, management of these patients. Suppose there's a known patient of a suspected malignant pleural effusion and he's asymptomatic. So we don't do pleural intervention in these patients unless we do it for diagnostic purposes. If the patient is symptomatic, ultrasound-guided therapeutic thoracosynthesis can be done, a large step can be taken, and we can look for the improvement in dyspnea. If there is no improvement in dyspnea, we will look for an alternative cause, whether the patient has a PTE, patient has a CCF or something else, or a intrabronchial lesion and a collapse of the lung. If the patient has improvement in dyspnea, then we look for lung expansion, whether the lung is expanded or not. If the lung has not expanded, then we look for whether the survival is long or not. If the survival is short, the lung has not expanded, then it's better to just give palliative treatment. We just palliate the dyspnea, we give oxygen, we give morphine, we take care of pain and make the life comfortable as much as possible. If the patient's lung has re-expanded, but the predicted survival is more. If the patient's lung has not re-expanded, but the predicted survival is more, then at that time, IPC is the treatment of choice. Pleural catheter can you put in, and over a period of time, we can see sometimes there can be lung re-expansion. The lung re-expands, we can then put in a talc slurry or we can do a pleurolysis after that. So if the patient has improvement in dyspnea, lung has re-expanded, then we can discuss give the patient the option of indwelling pleural catheter versus pleurolysis or the combined approach. Sometimes what happens, pleurolysis fails because the patient has a recurrent reaccumulation. So the surfaces are not able to oppose. So that time what we can do, we can put an IPC, buy some time, and over a period of time, either it will be a spontaneous pleurolysis or the pleural fluid output decreases, and then we can go for talc installation and pleurolysis. These are my references. Thank you so much. Thanks for the patient listening.
Thank you very much, Dr. Syed Mudasir Qadri. That was an exhaustive one, I would say. You've covered almost all points, really not leaving much for the panelists. However, that would help the panelists to take it from here and give their expert views. I'm just going to jump on straight to Dr. Nitin Abhyankar, whom you all know. He's a veteran in this field, interventional pulmonologist, has a great background of medicine, a European diploma in chest medicine, and he works at Pune Hospital. What I have for you, Dr. Nitin, not really specifically to you, but as a pulmonologist, what would you think of the role? Should a patient with lung cancer with pleural effusion be denied surgery, in your opinion, from a pulmonologist point of view? Briefly, Dr. Nitin Abhyankar.
I think it's a tough question, and Nasser, you are expert at asking tough questions. So I mean, most of the times it will be not a great idea to involve a surgeon upfront, obviously. But then there are certain situations and certain tumors and certain pleural environments which will be eventually taken care, and a surgeon can walk into the picture. So I think, I'm sorry to disappoint you that maybe 95-96% of the times we will not refer it to Dr. Nasser in Kochi, but then, there would be some situations where, yes, the surgeon has an important role to play. So I think it's a minority role, but an important one. And that needs to be identified depending on what kind of a tumor it is, what stage remaining. The fact that you are involved in pleura, the grade gets upgraded, no question of course. But at the same time, all said and done, it depends on the tumor type. What is the original process? Where is it? And is it amenable to surgery or not? So there are a number of situations where we do anterior chemo and eventually refer it to surgeon and so on and so forth. So whatever those situations, they are minority. What Dr. Syed referred to is that most of the malignant pleural effusions are like we are looking at palliation. But there are some situations where, Manjunath as well as Dr. Ravi Chandra as well as Dr. Nasser will be walking. So I think there would be situations like that. Small percentage.
Can I invite Dr. Manjunath Bale, if he's around, surgeon from Apollo Health City? You're not on video, are you?
Yes,
sir.
yes.
Please. He works at Apollo Health City, Hyderabad. Young guy, did his training in All India Institute. Let's hear his opinion on, has surgery a role in a patient with lung cancer with malignant effusion? Welcome, Manjunath, please.
Yes, sir. Good evening, sir. And good evening, all the panelists. I'm the junior most, I think, in this whole panel. My opinion is if a patient is having recurrent effusion and if the lung is not expanding because of a thick layer of parietal visceral pleura, then that is one of the conditions where I would still think of doing a decortication, because patient is having dyspnea because the whole of one side of the lung is not expanding, it's not contributing to the ventilation. So that is one of the things. Even if a patient is coming upfront to me, I would offer a decortication for in that condition, sir. Although we know that even if it's cytology is positive for malignancy.
Good. Thank you, Manjunath. And basically, as Dr. Qadri and Dr. Nitin said, surgery is not the answer for this. If in extraordinary situations where everything else fails, as a palliative procedure, there is an option, there is hope, and we can give considerable relief to patients. For example, when, as you rightly said, recurrent effusion, you're tapping, but the lung is expanding, we can probably consider surgery. But keep in mind, so basically it's a medical problem. Basically, it's the pulmonologist problem. Wonderful there. Now, can I bring in quickly, I'll get Dr. Qadri back in. What are the various mechanisms of pleural effusion? Could you just briefly tell us, short and crisp, in malignant pleural effusion?
So basically, one is the direct involvement of the pleura by the malignant cells. So they may cause an inflammatory response, increase the permeability of the vessels, and increase to hyperfiltration. Number one is that. And the other way, one of the major ways is by blocking the lymphatics, which are mainly present on the parietal pleura. So by blocking the outflow of the pleural fluid, there can be accumulation of pleural fluid. Then there are various indirect mechanisms. For example, there is an endobronchial growth, there is a total collapse of the lung, and there may be fluid on the same side. Then a patient can have malignancy-related cachexia, severe hypoalbuminemia, low albumin, low oncotic pressure, and there is filtration of excess fluid in the pleural cavity. So these are various mechanisms by which a patient can present with pleural effusion in presence of a malignancy.
Good. I think that completes that, the mechanism. Now, can I invite Dr. the dynamic, vibrant, energetic, I should say he had a main role to play in today's discussions, Vijay Kumar Chennamchetty from Hyderabad. I can take you to a different dimension. In fact, going to shock you with this statement of chylothorax, probably not directly related to malignancy and effusions, but does chylothorax have any significance in malignancy, Dr. Vijay Kumar?
Thank you, Nasser sir, for that kind words. Good evening, one and all panelists. Good evening, audience. Thank you at the outset. I sincerely thank Krishna Anna and the core team, Dr. Ravi Dosi and Narayan Pradeepa and Narender for giving me this opportunity to be along with the eminent members of Indian pulmonology practice and Indian thoracic surgery practice. Thank you. So, chylothorax, sir, generally we do see chylothorax very, very rare. Clinical scenario, it is not a common entity. But having said this, what I would like to state here is, we must keep this unusual diagnosis in our mind always. Whenever we are dealing with malignant pleural effusion, there's every chance that we may be missing this, because chylothorax is known for its recurrences. If it is not managed properly, definitely it's going to give us trouble. So for which we have to identify. So identification is by proper testing of triglyceride levels, And clinically, when we examine the supernant of the pleural fluid, if it is remains turbid, then you must suspect this entity. And once we suspect, we should examine the for pleural fluid for triglyceride levels. If it is more than 110, definitely it gives us a clue that yes, we are dealing with chylothorax. And if it is less than 110, we must also sometimes we may need to do electrophoresis to confirm the presence of chylothorax. And yes, rare entity, but we must think in almost every case with recurrent malignant pleural effusions.
Thank you, Dr. Vijay Kumar. He works in Apollo Hospitals in Hyderabad. And now the tricky question is to Dr. Ravi Chandra as a surgeon, or how would you deal with it? How would you treat chylothorax? Dr. Ravi Chandra works in Sakra World Hospital in Bangalore. He is a senior thoracic surgeon with focused interest in this particular area of malignancy oncology.
Yes, sir. Good evening, sir, and good evening, everybody. And first of all, I would like to thank the organizers for having invited me to be part of this panel discussion. Yes, sir, as Dr. Siddique has rightly said, especially when there is a recurrence or when there is a large effusion, we need to suspect one of the possibilities is a chylothorax. After having analyzed the fluid and we are sure that it's not just an exudate or a transudate, chylothorax component is there, we would have to suspect the nodes, the lymph nodes or a lymphatic obstruction for having caused this. So the next option would be to think about either look towards the mediastinum, look at the nodes to do radiation or chemotherapy, whichever is appropriate for that particular disease.
Yeah, Doctor, may I add something from my? I deal with chylothorax.
Yes, sir.
Mostly, it's not to do with malignancy, but how would you treat it? You have this problem. How would you treat it? You have the medical way of treating it, putting a chest drain, control the diet.
Yes,
yeah, please.
And then one of them, octreotide is an option. We need to give the injection. Sometimes we see that maybe after 3 to 4 days or even 5 days, the response will not be there. But after that, we see a response to the injections. So that is one way of where we can.
I think the diet alteration also needs to be mentioned, that you have to give medium chain triglycerides and see whether that is working, because short of octreotides, that is another option which is amenable. And then if it is not settling down by 15 days, then we must go in one way or the other. Whether you are going in the thorax or whether you are going in the abdomen, it depends on the situation, where the tumor and where the source of the whole thing lies. So I have gone right up to the abdomen in non-Hodgkin's lymphoma, and we had to in fact ligate a thoracic duct at number of levels, and still it wouldn't work. And then we had to do a abdominodesis. I don't know what the right term for it is, because we had to do that because the entire lymphatics in the abdomen were involved with the non-Hodgkin's lymphoma, and then we had to do that just to get rid of the chylothorax. I mean that was the extent that we had to go in. Of course, it's an exceptional case. It's not definitely going to be the standard of care for anybody, and most of us will not require that. But I think that needs to be kept in mind, that you may have to go back and keep tracing where is the chylothorax coming from. That's also important.
Dr. Nasser, if you permit, I will add one important case which we have come across. We have dealt almost a couple of years back. A disseminated tuberculosis patient. The only issue is she was medically manageable, but only issue was persistent chylothorax at the end of 1 year. And despite proper nutrition, despite proper anti-tubercular therapy, she was not gaining weight. So this was another, and persistent leak was an issue. So we went in and then we identified at just behind the retrocardiac area, and then close to hilum, there is a leak. So we just kept a Surgisil there and then pleurodicized the entire left hemithorax. Patient did improve very well. There is no more recurrence of chylothorax. Sometimes, it may work.
Yeah, I think the biggest problem there is, nutritional depletion of a patient. Because
Yes.
whatever is liver doing and, eventually bringing out back the whole story through the lymphatics and, back channel of that is thoracic duct. And if it is getting leaked into the pleural space and then draining out, it's a disaster. And then person rapidly worsens. So beyond 15 days, it is not acceptable to sit back and say one day things are going to get better. So that is where thoracic surgeons walk in, or the abdominal surgeons, or whoever it is. Wherever the block is, wherever the leak is, you have to get rid of it.
Excellent.
Further on, just for your, I would say knowledge, I wouldn't say information, is what do you expect from the thoracic surgeons? We have a couple of ways to do it. One is if we can identify the leak, great. But still, I would suggest go in and ligate at the diaphragmatic level as well as the subclavian level, so you are not missed anything. A mass ligation will cure the problem invariably. Follow it up with a pleurodesis or a pleurectomy. And that means that you are obliterating the space as well. It gives time for it to act as a sealant. Where Vijay was saying of using a Surgicel, this is an actual mechanical compressive sealant. And more equally, if not more importantly, is to take care of the diet. That is very crucial. You might do heroic surgery. You might do a lot of heroic interventions. But if you mess up, you lose out on the patient. If you mess up with the diet, you lose out on the patient. So nutrition and maintaining the status of the patient is the key point there. That was very interesting discussion. It went beyond probably our realm of discussions. I'll take you to another level. I just want to keep jumping instead of going the traditional way of pericardial effusions. Would somebody or Dr. Manjunath Bale come in and give your opinion? Because pericardial effusion comes in, usually the surgeons get involved. Yes. What is your take on this matter, Dr. Manjunath Bale?
Yes, sir. If there's a pericardial effusion, first thing we should try to see what's the main reason for it. Whether it's an involvement or there's a deposit. And as these patients are already not doing so great, the first approach would be to place a PCT into the pericardium, drain the fluid, allow it to settle down. And very rarely we have encountered a situation. There was one case with Dr. CVK itself, where the patient had a pericardial effusion along with pleural effusion. So we had to do both a combined decortication as well as a pericardial window. A small window was created for it, 4x4 window. Apart from that, very rarely we encounter a patient where we have to do a surgical intervention is required.
Good. Would Dr. Nitin or Vijay contribute on what's your opinion about pericardial cap, pigtail, and then putting a sclerosis in there? Any experience? Any?
Very rare to really get into a clinical situation where somebody has to do something in a malignant pericardial effusion. By the time I think somebody has a pericardial and usually a pleural, and then it's a disseminated malignancy. So very, very unusual. Once in a while we will come across that situation, but then I've never advocated a pleurodesis or a pericardiodesis or something of that sort ever. So it's going to be extremely rare. Possible once in a while, but not really.
But just to extend the quality of life, what I would recommend here is make sure that the patient is not in tamponade. If the patient is tamponade, make sure you drain the fluid.
Absolutely.
Involve the cardiologist, interventional cardiologist, make it drain thoroughly. And very rarely we do, yes, probably in 15 years experience, I have come across a couple of cases where we have ventured into the left thorax and then did a pleurodesis and then made a pericardial window and then came out by placing an ICD. Very rare scenario. I totally agree with Nitin.
Probably as surgeons, we see at least on an average, I would see in a year about 8 or 9 cases. Probably the complicated cases come to us. And the good thing about a pericardial window is that not only do we get a biopsy, but we are able to break. What happens is most of these patients come in with multiple tabs. So they start forming loculations just like you have in the pleura for pleural effusions and empyema. So we are able to break those loculations with the finger or with the suction. So we make it one compartment, the pericardium and the pleura, put in a drain, which we are able to take out in say about 3 to 4 days. So maybe you can keep in mind, and easier and better to go in early rather than late when it gets complicated. So please keep that in mind. I'm sure this is a happy platform where we can have the pulmonologists, the interventional pulmonologists, and the surgeons sharing their opinions. That's very interesting.
Nasser sir, one more thing. When there is involvement of both the pericardium and the pleural fluid, I mean the accumulation in both the regions, do you think it's more to do with the constitutional, like nutritional albumin deficiency, or is it the disease per se and the additions, which is common when there is involvement of both the pericardium and the pleura?
I think it's the disease process. It's a rapidly progressive disease, and just to carry it further, last week we operated on 3 cases, which were supposed to be, according to guidelines, not inoperable, stage 3B. We had pericardial effusion, pleural effusion, and 1 solitary lesion in the lung with 1 contralateral node. We discussed with the oncologist and young lady. So it is a very rapidly progressive disease.
I think if you have to go by the tumor type, because non-Hodgkin's lymphoma, absolutely yes. Adenocarcinomas of all kinds, from wherever they are, that is also a very, very likely thing, because these are the 2 types which will really float up, in their ability to cause that much of pericardial effusion, apart from the malignant fluid effusion.
Now, can we have an opinion on this? Outcome of patients with minimal reactive pleural effusion. Interesting. Minimal reactive pleural effusion or cytology negative effusion. A patient comes who has malignancy, proved malignancy, and with minimal pleural effusion or cytology negative effusion. Can I ask the surgeon, what would you subject him to curative resection, or what would your approach be?
Sir, even if the cytology is negative, if there is a suspicion of a visceral pleural involvement in the preoperative phase or during the thoracoscopy or after a thoracotomy, the overall survival is definitely going to be lesser in those patients. In some studies it's seen that almost 50% of the patients there's definitely going to be a metastatic lesion in those conditions. So it makes it very tricky. And even if the cytology is negative, there are a lot of patients who have visceral disease, visceral pleural involvement, but there is nothing seen on the cytology. So, and the other thing is, even sometimes if we have a doubt, we send pleural fluid for analysis during the pleural lavage, basically. Even if that comes positive, the overall survival is drastically reduced in these patients. So, negative, it's almost like a negative prognostic predictor in many conditions.
But if you have a resectable lesion, solitary one in the lung, and you have this effusion, would you give the benefit to the patient or just leave them in chemotherapy and that's it?
If the cytology is negative, definitely I would give go ahead and resect. Also explaining the patient that there was some fluid and the overall survival could be lesser than expected in.
Nazar sir, can I ask you here? I am asking you as a senior most surgeon in the field of lung surgery. What do you do in such a case? One important. And second important thing, when you get into the thorax, what makes you to decide whether I will straight away go ahead and then resect this lesion, or no, Baba, this is enough. I don't want to subject this patient to curative resection. What is your take?
Thank you so much for asking that. It's a very dear question to me. We have a lesion in the, say, lower lobe, and we have effusion, minimal effusion, patient is young, right? You have guidelines which say he's condemned. Right? First, in these cases, we discuss with our oncology team and reach a learned decision. If the lesion, the patient can be resected, we go in, we assess the pleura. It's very gross, huge pleural deposits. Well, the matter is settled there and then. But you have small, tiny nodules which can be, can do a pleurectomy. We can do that pleurectomy. One advantage of doing a pleurectomy sounds morbid, my dear friends. In the literature, it's not as morbid. It's not as morbid as these guys make out. So you can do a pleurectomy if nodules are tiny. And again, we'll do a pleurectomy only if the lesion is, for example, a lobectomy can done. We can attempt, inverted commas, a curative resection. With a curative intent, we would do a lobectomy. On the other hand, we go in and we find gross, huge pleural nodules. Well, it will be a palliative procedure. Then leave it to the surgeon to do a local resection. But gross pleural nodules, effusion, which was not detected on CT scan, I would probably make them comfortable and leave them alone. But young patient, tiny nodules, minimal effusion, I would go in and resect. And let's see that you have chemotherapy and all that. And we can never know what will happen next 2-3 years. We are down the road. This is a personal take.
Because that's a huge area. Yeah.
Can I come in? Vijay, can I come in?
Please, sir.
The targeted therapy, particularly with the kind of, where it works with the kind of receptors, has changed the profile of lung malignancy dramatically over the last 2 decades. And with appropriate guided targeted therapy and a well-intentioned, correctly planned surgery, things can be dramatically different. In fact, I was a part of AVESA trial, which was when it first came. That was the first gefitinib, if I'm not wrong. And I forget the names of gefitinib, ablotinib, and after that I have lost the. So there are so many tinibs there. God knows. Kind of impact that they have on the survival of malignancies has been phenomenal. And therefore, I think die hard or never say die is the best approach, as long as what he said is right. If I'm studied absolutely with the metastasis and the patient is cachectic and he's 70-year-old and he's not going to make it, don't touch him. That's logical. But for a 30-year-old, saying that the guidelines are putting it as this pleural effusion is out of bounds to you and you should not be operating on those nodules. That's again not correct. So I think you have to individualize and you have to look at what kind of tumor type, what kind of a sensitivity, what kind of mutations are you having at your disposal. And that will make your complete decision.
There you are. Wisdom speaks now. We have to be wise. Thank you for bringing that up, Vijay. That was great. On a personal level, that was good.
Sorry, sir. Can I ask one more thing? So, if there is a fluid and you don't find any nodules, then what would you do, sir? What would you do? Do you still do a pleurectomy?
Sorry?
Yeah. If there is effusion and we can't see any nodules, there is no deposits, nothing. Right. So, would you still do a pleurectomy in that case, sir?
I would do it. If it is a massive effusion, I would do it because then you don't need to do any other procedure further on. That's a personal take, and I find this quite.
You are giving a huge amount of tissue, so you are not going to miss anything which is in the at least in the parietal.
True. I think we must be overstepping time. Can we quickly now move on to the next few questions and re-expansion pulmonary edema? And can we keep it crisp and short, gentlemen? Nitin, Vijay, maybe Vijay can start it off.
Nitin.
Expansion pulmonary edema.
Vijay hasn't spoken for a while, so let him start.
Okay. So just re-expansion pulmonary edema is one of the very, very common thing which we do come across in our practice. So the moment you see malignant effusion patient will be in emergency room or OPD, you will rush the patient to wherever. Okay. Generally, procedure area and try to tap it. Okay, the moment, my dear friends who are listening, please remember, the moment patient starts coughing, stop tapping. That is a very, very important. Okay, if you continue to tap despite the patient is coughing, okay, then you may end up in creating more amount of negative pressure, and then that causes more amount of negative re-expansion pulmonary edema. So make sure this is the earliest sign that patient starts having dry cough recurrent. Okay, that point you have to stop it. Generally, guidelines says 1 to 1.5 liter can be comfortably tapped, but in my opinion, generally I restrict myself. When I am tapping, 800 to 1 liter is the one time go. But having said this, the same thing doesn't happen when you are aspirating after placing a trocar. That is while doing thoracoscopy. This is very, very important, because the moment you are tapping off or taking off the aspirating or suctioning the pleural fluid, you are also entering the equal amount of air into the pleural space. That makes your job very comfortable, and then patient will not experience this re-expansion pulmonary edema in your practice. That is a very key point that you must remember while doing thoracoscopies. Don't get worried about tapping even 2.5 liter or 3 liters, because whatever intervention you want to do, unless you empty the entire pleural space, you cannot visualize the lung surface and parietal pleura. So please aspirate as much as possible while doing thoracoscopy, because re-expansion pulmonary edema never occurs while doing thoracoscopy. Nitin bhai, please add kijiye.
Yeah, I think the limit I have reached is 6 liters in one go, and the patient did not have pulmonary edema. So it depends on, I wouldn't imagine, because that whole fellow weighed about 45 kilos. So I removed 6 liters of what was left. So, it's as bad as that. But even with that, of course, it's what is a transudate, and we were trying to do a silly procedure like fluoridesis, which we never worked in that poor fellow, because it was related to cirrhosis. But then, so I think the amount doesn't matter. How is the patient physiologically doing during the procedure? And that's a very subtle clue that he has talked about, the cough, which is just not going away. And that's important. If you identify it early enough while tapping, you are going to stop early, and you are going to make the patient safer. In simple words, the moment, I see a lot of interventional radiologists who are very fond of saying, I tap 2.5 liters and 3 liters and things like that. That's silly. That's not the right way ahead, because you have to stop somewhere. And that somewhere means the physiology is going to maladapt for some time and then readapt. What are you doing with the thoracoscopy? You are allowing the time, because there is an open space which is available to exchange and have equilibration of pleural and intrapleural pressures and extrapleural pressures, so that the lung expands in a relatively slow manner, and therefore it doesn't get into the flash pulmonary edema. Simple. If I am tapping relentlessly, it's going to be a disaster if those pressures are changing rapidly. So I'm definitely do not belong to the class of where we say put in a needle and leave it behind and just let it drain. That's not what I want to do. I would want everybody to tap it syringe by syringe, stand there, make sure that you're watching the patient. You don't have to stand there because you are on the duty. No, you are there because you are watching them physiologically, what is happening to them. So simple tip is do not ignore what is happening to the patient. That cough which Ravi talks about, Vijay talked about, is very important. If it is not going away, you have to stop sharp. And that's where physiology changing rapidly creates a disaster. So amounts, yes, there are number of amounts which you have mentioned, 1,000, 1,200, 1,500. But if somebody is getting relentlessly restless after even 800, I'll stop.
Yeah. Dr. Qadri, yeah?
So can I add something, sir? I think just to take care of this, that the patient doesn't develop this re-expansion edema, we can use pleural manometry. So we can have a check on the pressures. So usually we should not go less than 14.5. So once the difference between the initial pressure and while we are draining it, if it goes more than that, the chances of expansion edema are more. And one more thing that what we have noticed.
Are you, Dr. Syed, are you using routinely this, or is this from the books?
No, I'm just saying we're not using it. I'm just saying adding.
No. Then let's come back to what is real life scenario.
Yes.
If you are measuring it, hats off to you. I mean,
It's very difficult procedure. I know there are limitations.
30 years and I have not done it. So come on.
So they have tried to overcome it by double lumen so that we don't have to wait. Yes, this is one procedure which can be used, not being used very commonly.
Absolutely, point taken. But then, where are the pleural manometers in commercial practice?
Absolutely. So one more point that I have noticed in our practice that we do, I am yet to see one patient of malignant pleural effusion getting a re-expansion edema. Yes, I have seen many non-malignant effusions getting re-expansion edema. So there I'll be very, very careful in draining. I usually do not drain more than 1000 ml in a non-malignant effusion. But in malignant effusion, somehow the mechanics are so that somehow there's some kind of there's a resistance to REPE. Plus, yes, we do pericoscopies, we do other procedures by which there's a balancing of pressures, and the expansion, the chances are less.
Interesting finding, Dr. Qadri. And for completion's sake, you probably mentioned manometry. However, I think we spoke about aspiration and we spoke about thoracoscopy. What about an intercostal drain?
Yeah, I think I'm going to come out on that. And intercostal drains of various types available. This country is huge and diverse, and all kinds of cares and levels are available. Indwelling pleural catheter at this point in time, guidelines recommend it the best. No question about it. There is no two thoughts about it. But at the same time, I see patients with, I had a patient with a 32 French drain who is 32 kg lady. God knows how she was tolerating it for such a long time. And then, crazy kind of sizes that we are sort of conventionally taught about. Smaller is the best, no question about it. That's number one. As long as it is draining, and of course that intrapleural catheter placement for a malignant pleural effusion is possibly the standard of care, not for today, very frankly, let me confess that at this point in time, but it is for tomorrow. So I'm going to, if Dr. Nasser allows you to take you all through a video, I'll present a simple video and then 3 or 4 minutes, and then we'll come back to that. I'll try and fast forward the video so that the unnecessary details are taken out of it. Is that all right, Dr. Nasser?
Yeah, can we have that video? Yeah, please.
Yeah, I'll do that. I'll share my screen and hopefully I'll locate that. Well, there you are.
In the meantime, Dr. Vijay, could you already talk about CT and chest X-rays, pleural effusion?
So basically, what we do, earliest signs of pleural effusion in the chest X-ray is subpulmonary effusion. Yes, sometimes there may be pleural adenocarcinomas. There need not be any adenoceal mass lesion in the lung parenchyma. So in such a case, what I did notice, and even evidence says, is almost 50%, close to 50% of undiagnosed pleural effusions are, at least in our experience and even Western literature, close to 50% are malignant pleural effusions. So slightly, I can say 45% is malignant, 55% is benign, like that. But having said this, when we look at the CT scans, what we need to look into the signs are pleural nodularity. If you identify pleural nodularity, the chance of having a benign and malignancy is both are there. But having said this, if the nodules are coarse, the chance of having a malignancy, particularly mesothelioma, is pretty high. And similarly, if the mediastinal pleural thickening is there, that's one important thing. And if the thickening of the pleura, at least with nodularity, is more than 1 centimeter, then the chance of having a malignant pleural effusion is very, very high. So I suggest in these scenarios, we have to make sure that we have to do a thoracoscopy and diagnose appropriately, or at least CT guided biopsy. I
think I've somehow located the video back again.
Great,
so
wonderful.
Yeah. Is it visible to you?
Yes,
Yes,
yes.
yes.
Yeah. Okay. So I'm going to fast forward this into actually the real procedure. So there are a lot of equipment there, and which are. So this is your silicon catheter which they are showing you. Yeah. So there is a needle and a syringe there, and then there are other equipment. So I'll fast forward to that. I don't think we need to go through all that. We'll go to the procedure straight away. Yeah, that's where. So this procedure can be done in OPD settings, and of course can be done under a little bit of sedation if that is desired by the patient or by the doctor, whoever is more scared. You have to look at 2 points. So about 5 centimeters away, one point is where the insertion is, and the other point is where the tunnel is going to come out. So this is one, and say about 5 centimeters away from each other. So you're going to put a needle there and make sure that you are aspirating fluid freely. So you are into the pleural space. Yeah. Then put in a guide wire, of course. And then you take out the needle. Yeah. Then you are going to create a track so that the guide wire is pulled from this end out. So the IPC goes in. Yeah. And then you find the guide wire, and yeah. And this is important, that this Dacron cuff, which is going to cause fibrosis and will seal this area, is under the skin. So you go in with a dilator into 7 centimeters. So you are into the pleural space with a much better dilatation. Now the catheter, yeah. And make sure that the catheter goes in comfortably without kings. And once you have done that, you know you have to just take care of the sutures on both ends. And this is where your Dacron cuff will be lying. This one will cause fibrosis. So I'm going to pause this or sort of stop share, and then we'll go back to. So all we are doing is making sure that there is a intrapulmonary catheter in place. That 5 centimeter tunnel with the Dacron sheath, make sure that you are not going to dislodge it easily, because there is a fibrosis around that Dacron sheath. So that subcutaneous tunnel and that Dacron sheath, make sure that it is not going to easily come out. Then it's a matter of just aspiration. So whether you attach a bag, or whether you attach a negative pressure suction, or whether you just attach a 3-way valve and syringe and aspirate, it depends on your situation, scenario, availability, resources, and all that, and what kind of a caregiver you have at your disposal. The cost is the main issue at this point in time. And in fact, if you really see why we are still dealing with intercostal drains and pigtails and whatnot, is essentially because this whole gadget is silicone, particularly the catheter is silicone, and it's expensive. The commercial price first time when it became available was around 55,000. It has come down a bit, but it is still not affordable to the majority of the malignant effusions that we are dealing in this country. And if you really see seriously, that last 3 to 4 years, of course, get out of those 2 years where we had, practically 1.5 years, we are living with COVID and we have ignored everything else. That's a different story altogether. But all said and done, I think it has not really caught up mainly mainly because of the cost ambitions. Because I right now have a patient whom I have advised, counseled, he's ready for it, he's arranged, maybe he has arranged it, maybe he has not arranged it, but a 55,000 rupees worth catheter is expensive for majority of the Indian population who are, I would say, below middle class. And in that kind of a scenario, I don't think that's the right answer, rather than, and therefore I weigh the situation in this context. And what Vijay does often, or what I do often, is land up doing a pleurodesis one time, once and for all kind of a procedure, rather than managing. And the other issue is intelligent care. So that's the second part of it. You can't have an idiot who's looking after whatever catheter in the world, the best catheter, gold plated or chromium plated or whatever that material that you are going to use. It's not going to be useful if you have a bad caregiver. So I think that's the second part of it. So if you have an intelligent caregiver, affording patient, MPC, IPC is the best kind of a device, because in 40-45% of the situation, it will cause an autopleurodesis. So you won't realistically need a talc pleurodesis or a betadine pleurodesis or whatever options you have at your disposal. So I think one has to weigh these pros and cons, look at a patient on individual to individual basis. Somebody who has got less than 6 months in a bad situation, absolutely, if he's affording an IPC, I'll put an IPC for him. That's the right thing. If somebody where I'm not so sure about the caregiver, the affordability and all that, I would still end up doing pleurodesis. Methodology may differ from patient to patient, situation to situation, person to person, availability basis, and cost consideration. So I think all those will play a role. But I think IPC at this point in time is the most recommended therapy worldwide. The world doesn't include Afghanistan. So of course, we are talking of situations which are realistic and sensible. So
Nasser sir, if I may, Nitin bhai, if I may add here, okay.
Please.
Yes. So, fantastic, conclusion points. I totally agree with you. Slight differ is if the patient is reaching hospital every, weekly once or weekly twice for tapping, that costs much more. So my dear friends, please note this. Okay, IPC, yes, when we started, we are one of the first persons to import Pleurex catheter from West to India. Okay, this is almost 10 years back. So when we started placing, it was costing $1,000. Okay, and it used to take, very tedious DGCA clearances, not there, all those things. But having said this, now it is available for close to around 25,000.
Yeah.
Okay, 25-30,000. That's it. So it's a one-time procedure. And as Nitin bhai has concluded very sharply, that autopleurodesis does happen. 2 months down the lane, I have seen close to 9 out of 10 patients who are surviving still. Autopleurodesis is happening, and automatically you can pull out the catheter very easily. So IPC is now the order of the day for patients who are going to, yes, as Nitin bhai rightly said, we're going to survive for only 2 months, 3 months, 6 months kind of thing, rather than investing in pleurodesis, thoracoscopy and all those things, which is more invasive procedures. And another important thing for juniors who have not yet started practicing IPC, it is for to look the video or to read the points of insertion. It may be really looks like somewhat very complex scenario to place it, but mind you, it is very, very easy and almost similar to placing. If you can place ICD comfortably, you can might as well place IPC very easily. Please note this point.
Yeah, I think it's a very important point, that the ridiculous simpleness of it, that it is done on OPD basis in the Western settings. OPD basis. They don't even admit the patient. They place a catheter into the pleural space on OPD basis. All you have to make sure is you are not draining 2,500 ml on first day. Then that becomes a pre-expansion pulmonary. So don't do that. Do it over a period of time. Who has That's the typical beginner's when I learned central venous catheterization, it used to be a subclavian line, and the moment the catheter would go in, I would have crossed the left atrium or whatever in the outflow tract is, because you are so enthusiastic. The catheter is going in, I am going to do everything. So same thing will happen with the young enthusiastic pulmonary fellows, that when they can tap, they want to tap everything that they can and resist that temptation. Stop short, do it in bits and pieces, do it over a period of time. And of course, what Dr. Syed was saying is that in the malignant effusion, you could get away with a little bit of a murder, but then don't commit murder unless until it is absolutely necessary.
I see young enthusiast. Dr. Qadri wants to comment.
Yeah.
I just want to add one point. I think IPC basically is definitely a big way in many of the patients because we see a lot of malignant pleural effusions, they get reaccumulations. So we try periodicities, they fail again and again. So rather than going for that, I think putting an IPC is so simple and getting rid of so many things. It's very, the pain is very less, infections less, quality of life it improves. I think we have to break a barrier, and definitely it is one of the big ways.
I think the point is extremely well received, and with that cost of around 25,000, it becomes much more realistic than doing a thoracoscopic fluorodesis. So I think even the talc alone will cost you maybe, for 2 gram talc today, the cost is around, MRP has reached around 5,000. So for 4 gram talc, it will be 10,000. So I think in any case, the talc cost alone will prohibit you from putting, doing a thoracoscopic talc fluorodesis. The betadine, of course, is much cheaper, but then I think that's again, it's not as effective as talc. So I think you have to pay the balances. So I think what you have to do is use it on patient-to-patient basis. Carefully select your patients of whatever intervention you think is appropriate, and do think of IPC as an important first step when you're not sure, particularly if you're not sure about the lung expansion. IPC is the right way ahead. In fact, particularly in a partially expandable or a trapped lung, IPC is absolutely the way to go forward, because the moment you put in a catheter, you are creating a scenario. Maybe the lung will expand after 2 months. You don't know. And then the talc fluorodesis will become effective. So you don't know at that point in time what kind of a lung physiology will be existent. The chemotherapy may work, but the targeted therapy may work. So I think you are creating a better chance rather than trying to. I think the most important point, sorry, I'm taking a little longer, but the most important point I would want to make is, if you're not sure about the lung re-expansion, please do not pull talc inside, because that is going to be a disaster, because it is going to cause fibrosis on both ends and they will never meet. And then you will never have the reunion of the parietal and the visceral purula, and that's a disaster. It's absolutely not. So in case you are not sure, just put in a drain or put an IPC.
Yeah, Vijay.
Yes,
it's
sir.
only 9:20. I don't know what time do we have to finish. 9:30.
9:30.
9:30. I said we so I'll have to fast forward.
Or 9:45. We can set.
Yeah, I said we have to.
There are 1,300 logins as of now. The good amount of people, pulmonologists, they are watching us.
So I think we can fast forward.
Yes,
keep our discussions to the minimum. Otherwise, we might lose out on things. That was very interesting, Nitin, because the point you have stressed is intelligent care. That is so. I have many experiences where people mess it up later going on. So that was a good point. Quickly, Vijay, now I think we'll have to fast forward. It's not fair.
please.
Yeah. Briefly, what do you think about immunohistochemistry in effusion? Briefly.
Nitin, please go ahead.
Nitin or Vijay, anybody? Vijay, how about you?
Yeah, IHC plays a very crucial role. So make sure that as soon as you receive the cytology sample as a positive, the same cytology sample can be processed for assessment of primary malignancy as well. Make sure every cytology sample is assessed for IHC, because it is a very simplest way that we can, and within 12 hours, we can get the diagnosis of where is the primary. That's it, sir. Thank you. That's the quickest way to answer.
Thank you. And what's the overall prognosis of a malignant pleural effusion? I'm moving fast. Or Kalinowski's performance. Would the surgeons like to come in, or shall we get the pulmonologist?
Yes, sir. I can talk about it.
Okay.
Please, Manju, please go ahead.
Yes. Sir, in major studies, what they have found is either ECOG or colonoscopy. These are the two main predictors of the overall survival. If a patient is ECOG 0, then we expect a survival of as long as 90 months. And if the ECOG is 3 or 4, the survival has come down almost to 6 months. Or in majority of studies, the median survival is say about 9 to 12 months. And colonoscopy score, if it's less, it is a direct predictor of a poor prognostic factor. The other things which are generally seen is ovarian cancers have a slightly better prognosis and compared to other extrapulmonary malignancies. And,
Good. Just a practice thing, because breast malignancy is one way or the other have beaten all kind of expectations. And if I have breast malignancy, I never give up. That's one. There is another score which has been mentioned. It's called Lent score. It has not been very well validated. It depends on the type, and then what ECOG score is also included in it. All those. So, but then I think rather than going at the scores, you look at the patient in total and look at what kind of cachexia he has, what kind of realistic life expectancy he has, whether he's hypoxia or not at rest. All those simple parameters would tell you whether this man is going to make beyond 6 months or not. So I think that becomes a much better evaluation than just looking at some number where you are saying, okay, on the basis of this number, I think this patient is going to survive for 10 years. It's not realistic.
Another thing is if the cytology is positive, that itself is a very poor prognostic factor.
That's a poor prognostic. Yes, absolutely.
So thank you very much. Malignant mesothelioma, any takers on that?
Yeah, I would like to invite opinions from surgeons here, because we read a lot about HIPEC. Okay, heated intrapleural cisplatin therapy while combined with extensive pleurectomy surgery. And in fact, today morning I did receive a teleconsult from one patient where our team has operated almost 8 years back. Okay, malignant mesothelioma with radical pleurectomy and heated intrapleural cisplatin therapy. The patient survived 8 years. Now she is doing very well. So, and the recurrence at this moment is very uncommon. Okay, after initial 5 to 6 years. So your surgeons, 3 people are there, 3 giants are there.
No, but can I invite Dr. Ravi Chandra to if you have a video to share, pleurectomy, or anybody has a video on pleurectomy?
I have done pleurectomies.
Any video you have?
Yes,
What video do you have, Dr. Ravi Chandra?
Sir, I have a video of decortication, sir. I think Dr. Manjunath would be sharing that video of.
Nasser, sir, another important thing is we pulmonologists. Can you please, differentiate between what is the difference between pleurectomy and decortication? That's
okay. So, Dr. Ravi Chandra, can you take that and then show your video on decortication, please?
Yes. Sir, in a decortication, what we do is.
Can we please video
you go in and remove all the, basically. Yes.
Manju, meanwhile, please add your comments.
Yes, sir.
So, yes, sir. Is the video visible to you all, sir?
No.
Is the video visible, sir?
No. Share your screen first, please.
Yeah. Just a second.
You take your question, Vijay, on pleurectomy.
Yes, sir.
You ready? When you're ready, just raise your hand. I'll stop. Pleurectomy would mean remove.
Yes, sir. Please.
Removal of the parietal pleura. Correct? Now, that per se from the chest wall is not too difficult. The challenge arises when you're dealing with the mediastinal pleura and the diaphragmatic area, if we are talking of total plurectomy. And that is what is required for malignant mesotheliomas. However, most people do not touch the diaphragm because it bleeds torrentially. Ideally, you should remove from the chest wall, the mediastinum, and the diaphragm. And here we have the video of Dr. Ravi Chandra. Please, Dr. Ravi Chandra.
Yes, sir. Yes, sir. I would like to share a video of decortication in which, we can see that we've got very thickened the adhesions between the parietal and the visceral pleura. So initially you try to release all those adhesions there. In such a situation, it's very, very unlikely for the lung to expand, no matter how many times we have tapped or anything else. And also, this is not a very, in fact, it's not a very appropriate case for, a talc, porterage, or a slurry, or any kind of a pleurodesis, chemical pleurodesis. So the appropriate thing would be in this situation is to remove all these fibrin deposits, to remove the adhesions, and also to clear that some of the parietal pleura, which we can see some of the fibrinous have to be removed surgically. We can see all these loculations here, probably because of repeated thoracentesis or even fibrinous deposits having been formed there. So after having released those peripheral adhesions, we go to the surface of the lung. Here we find that there's such thick visceral surface, so there's no way that it can expand with any of the other methods. In this case, we need to surgically remove that outer layer covering the visceral pleura and facilitate the lung expansion. So once all these thickened areas are removed from the surface of the lung, there we can see some kind of lung there deep to those the thickened pleura having been removed. Then we go ahead with a mechanical pleurodesis.
So, Dr. Nasser.
Yes, sir.
Dr. Ravi Chandra, you made a statement
Yes, sir.
about decortication not working very often, or maybe I didn't probably grasp it. What's your experience or the success rate of decortication? And most importantly, I have a little experience in that, so I have my views. What is in your view? When should you do decortication, and when should the referral be?
Yes, sir. I mean, most of the malignant effusions, it's as we've overall, it's a medical take. We have seen the other methods, and also we have got the flow chart to follow. Well, for a surgical intervention, I think the first and most important thing is the longevity, the expected longevity of the patient. If it is, it's very short, then there's no point in offering a surgical management. Go in and do aggressively and do something, and very shortly to find that the patient is not doing well systemically. So if the patient has good longevity, at least say 5 to 6 months, then probably we can think about doing something to relieve the patient's dyspnea. We need to release those adhesions. We need to make the lung expand to a large extent. Once, because we know that when we do a VATS surgical, you go in by a VATS, you remove all those fibrinous layer on the visceral lung. Very, very likely that the lung will expand. Also, it will very much facilitate pleurodesis following decortication and removal of all those fibrinous and these adhesions. And we can successfully perform a pleurodesis. Also, we can hopefully look forward to a good quality of life, devoid of any kind of a dyspnea or recurrence of those effusions. Probably will be avoided with this this particular surgical technique.
Good, thank you.
That is
thank
one
you.
thing. The other thing is, of course, there there are things, the scale, the Karnofsky's performance scale, ECOG scale, but along with that, the overall thing is the clinical impression that we get once we look at a patient. Probably will have, looking at the overall thing, we will have a feeling that yes, surgically we do something and that we can expect the patient to do better in, say in the next 6 months, and hopefully the other methods, the chemotherapy and whatever, they help for the patient to live for some more time.
Thank you, Dr. Vijay. I would like to add one thing to my pulmonology friends. If the lung is not expanding after you drain the fluid, do not delay it. Beyond 2 months or 3 months, this is not going to work. So better to get it done earlier, the better is the result. Dr. Vijay, could you just, if you have a video on thoracoscopy, could you just share it with us and talk a bit about intrapleural chemotherapy at the same time?
Yeah. So, my dear friends, first, hope my video is visible.
Yeah, it is.
Yeah. So it's a simple procedure, simple video, small video, so which makes sure that you understand how the talc pleurosis looks like. It's a snowstorm appearance, but what is very, very important is, please remember, the placing of first port is most important thing. Make sure that you don't harm the lung while placing the first port. And after that, it is very, very simple to insufflate that talc using the balloon insufflation. So it is very, very important to make sure that the talc is spread over all over the hemithorax. That's what it is. And meanwhile, intrapleural, sir, may I have the question again? Intrapleural chemotherapy.
Exactly.
So intrapleural chemotherapy is not a standard of practice anywhere. But having said this, there were a couple of studies which have been published in the literature, which does say that there is some role. But when we want to give intrapleural chemotherapy, there are some agents which intrapleural, some agents like methotrexate, they can get retained in the pleural space, and then they have a long-term side effect. So make sure that you're not using methotrexate kind of like drugs when you are using intrapleural chemotherapy. Sometimes cisplatin and pemetrexate works wonders in few patients, but it is not standard of care anywhere so far, to my knowledge. I welcome some inputs from Dr. Nitin as well.
Yeah, I think the one additional point, because Vijay, your point about chemo is well taken, it's not standardized, but there is data and documentation on the fact that intrapleural talc done for pleurodesis has a significant anti-malignancy action for a sufficient duration. So that is one thing which has been understood and documented over years, that any kind of pleurodesis, talc is one best example because it has got the best success rate. But even a betadine pleurodesis will have impact because of it has that action on TGF beta and various other chemical messengers and cytokines and so on and so forth. One way or the other, they seem to be having anti-malignancy action by themselves, which, of course, I'm not saying that obviously we have to give appropriate chemotherapy for an appropriate patient, but this adds value to some of the patients. I'm not saying that, once again, the pleurodesis is the better way than anything else. No, not at all. But at the same time, if you land up doing pleurodesis, you have that for whatever reason, you may have some ongoing anti-malignancy action. Worth remembering.
Yeah, so, a rapid round. Quickly.
Manju has a video to play for 2 minutes, I think, Dr. Manju.
What is it about? Manju, you have to unmute yourself.
Yeah, yes, it's about pleurectomy. If time permits, I can show a 2-minute video.
Sure.
2 minutes, please.
Yeah.
So this is actually a pleurectomy done for a benign condition, as Dr. Nasser said. In a benign condition, our interest is not that we remove everything. But since in this case I had removed most of the parietal pleura, I wanted to show you this video. Initially, we do parietal pleural scoring. In this case, we just try to make incision. Either I use a hook or I use some energy device just to give a small incision on the pleura, and then whatever place I get a flap, I try to hold it, and then gently we try to extend the pleural incision. Once we have a hold of the pleural incision, we can start removing the parietal pleura with both blunt and blunt dissection. I generally use either the suction or I use a gauze with on a instrument, and then gently separate the parietal pleura from the chest wall. One important aspect while doing this is you have to be in the correct plane. Otherwise, there is unnecessarily nuisance bleeding, which can really trouble you and prolong the operative time also. So if so for example, in this case, yeah, we are able to identify the right plane, and then we are just extending it. So almost at the after like about 20 minutes of dissection, this is what we had. The whole of the apical parietal pleura was in our hand. Gently, we just go further down and then dissect the whole thing out. Good. As Nasser sir said, the tougher part is the apex at the Gibson's triangle, where we're worried about the subclavian and the medial aspect, where we're worried about the hilar structures and the diaphragm, because the diaphragm bleeds more. This is actually the simpler part. What I'm showing, this is much simpler area where we can do the dissection much more comfortably. So this is the parietal pleural flap which is raised. We can almost extend almost the lateral parietal wall is actually the easiest one to begin with, and it's like this is more at the apex what is there. So this is all about a parietal pleurectomy. At the end, we should have a good view like this, where the layer of the pleura and the lung are clearly seen, and the dissection can be carried on in this fibroflatty plane.
That's a good video. Thank you so much, Manju. Thank you very much. Quick rapid round. After thoracosynthesis, what if fluid is replaced by an air pocket? Nitin?
Not a problem, as long as the patient is not very bad. Okay. Even after a effective pleurodesis, if I am left with a small amount of air on top or small amount of fluid, it's not a big concern, because I think one of the big statements I heard from a very big veteran, Dr. Praveen Mathur, who was the person who wrote medical thoracoscopy in Annals of Medical Clinics of North America in so early on. And I learned my medical thoracoscopy skills reading those books. And he said, in a malignant effusion, if you don't have 100% success, it doesn't matter. Even if you have, say, 75-85% success, it's good enough. So as long as the patient is not symptomatic, it's a good enough pleurodesis. So you don't have to look at 100% success rate. That's important. That's an important bottom line, because people look at, say, oh, there is a little bit of a pocket left, either of a fluid or this. As long as you're not expanding rapidly, no problem. Leave it alone.
Thank you. Good one. Dr. Vijay, role of pleurodesis in a partially collapsed lung? Yes or no?
No, sir.
Okay.
Absolutely.
And now the most common question, which I'm sure everybody...
Can I come in there? Sorry. One small interruption. Partial pleurodesis, how much matters a lot. So if I'm saying that 70% of the pleura can be pleurodesed and 30% can be left alone, yeah, I'll still do the pleurodesis.
No, Dr. Nitin, here, okay, it's a collapsed lung, partially collapsed lung. Yeah. So if it is not touching...
So if it is non-expanding, trapped lung, different story.
No. Yeah, that's what. So if it is a collapsed lung, no.
Point taken. I think let's go forward.
Can I add a point, sir? Can I add a point? If patient is symptomatically all right, even with a partially collapsed lung, and our worry is with further accumulation of fluid, he can deteriorate, why can't we offer a fluoridicist at that point?
So it's basically the very idea of doing a fluoridesis is to adhere the parietal and then visceral pleura. If they are not adhering, then there is no point. That's the only thing.
Yeah. So the obliteration of the space. Can we move on to the most, I think, the common important question? What is the ideal size chest tube for malignant pleural effusion? Dr. Nitin Abhyankar.
I started with 36 and then I moved on to 20 and I'm going down. I mean, I may reach 16 eventually one day. So I think 20 is what I'm steady with right now, but 20 is good enough. Much better than, yeah.
What about if it's an empyema, just taking it away? What
Even
size
with, even with an empyema, if I've done a good job of doing a good thoracoscopic adhesiolysis and making it into a single cavity, I still leave a 20 only. I don't need a 24 also, mostly not.
Okay.
Very rarely I put in a 24. Very rarely.
Is there any harm in a well-built person putting a 28 or 32?
No, I'm not talking of well-built person with 6 foot 9 inches or something like that. I'll happily put in a 28 or 32 also. Doesn't matter.
So, Dr. Vijay?
Yeah, 24 is what is right now I'm practicing for malignant pleural effusions. But what is important for young pulmonologists who are not well aware of these things, there are two methods of ICDs available. One is the what do you call trocar based approach, and other is without trocar. So when we look at the structure it is built, the trocar based approach, it has got a single eye in the end of the tube. And then when we look at the without trocar approach, there are multiple, almost 6-7 holes there. So when you are placing any empyema or malignant pleural effusions, my choice is always place a ICD which doesn't go with trocar, because this trocar one gets clogged and then chance of repeatedly replacement and all those things is very, very common. So my suggestion is, my dear friends, go with ICD without trocar. That is very safe. And then the size may be 24, 28, 20, depending on your comfort and experience.
Good one, Vijay. And a note of caution.
A small tip for the young ones. If you have a single eye one, you can do a microsurgery on that and create 6 eyes. Don't worry. All you have to do is bend it and cut it. Cut it just enough. Don't cut it through and through. So I have created 6 holes from a single hole. Doesn't matter. So that's not a problem.
Agree.
There's a slight problem to add. I didn't want to get into this. Is that when the other one is machine made, when we actually cut it, the hole becomes too large. There is a possibility while removing it, and it has happened, that it snaps.
That snaps. Yes,
so,
agreed.
So, but I'll come back to this, gentlemen, ladies, to be safe when you're putting a chest tube. If you're worried that the lung might be injured, I would suggest make about a 1-inch incision, dissect it right down to the pleura and put your finger in.
Absolutely.
That will be absolutely assured. The fear of injuring the lung is gone. That's safety is the better part of valor. And the last question I have here is, you have this, we talked of thoracoscopy, we talked of fluoridesis. We know fluoridesis can cause pain. What is the best analgesic here? Would you use NSAIDs? Vijay?
I am leave about the evidence, Dr. Nasser.
Yes.
So evidence favors, even you can use NSAIDs. But my practical point, my wisdom says is not to use NSAIDs. I totally depend on opioids. The wonderful opioids like tapentadol now, which can make our patients pain-free. And fentanyl patch works wonder, along with combination with high-dose paracetamol, 1 gram TAD, works beautifully well in all my patients.
Agreed.
Yes. I take that point absolutely entirely. But I think the fluoridesis is not a 15-hour, 24-hour procedure. It happens over a period of 1.5, 2 weeks probably. And the kind of adhesions that the good fluoridesis, particularly talc fluoridesis, creates, makes lives of Dr. Nasser and all the surgeons very, very bad when they have to dissect it out. So I think, so the inflammation is a slow process. So 1 or 2 days of NSAIDs, I'm not really worried about. If I have to give it, I will give it. It doesn't really matter. But at the same time, yes, point taken, fentanyl or patch or whatever else can work. I would try, definitely not give steroids. That is for sure.
Yes.
Gentlemen, I have no more questions. 9:48. Do we entertain questions from the audience, or this is it? What's it like?
You are the boss. Please take a decision. Right.
No, we can possibly take, if it's possible.
We must have driven them dead by now. Are there any questions?
Absolutely.
I don't see them in the chat.
If there's any question, we'll be happy to answer. Otherwise, it's been a wonderful evening. Thank you, everybody, for joining us. I hope it has been beneficial to you. I'm quite happy because it's been a very practical discussion. It's just not talking about that guideline or that research paper, that code. Here we are talking from our own experience, and I think that is the best, that's the richest, and that is what you need to telescope in your practice. I should thank Dr. Ravi Dosi, Dr. Qadri, the president as well, and Dr. Krishna for his Padma Shri. We are all waiting anxiously for that to happen, and hope it does happen. And Dr. Qadri, you've been excellent at this. Wonderfully well you did. So also Dr. Nitin, always wise with words of wisdom, ready to jump in and contradict if it's not, it's against his thoughts.
Ready to fight always, sir.
No. And Vijay, very balanced. And I hope you'll allow me to share the secret. Most of the questions were prepared by Vijay. Made my life much easier. And that was fantastic. Thank you so much.
So he knew all the scripts, sir, already.
True. Manjunath, young, budding thoracic surgeon, wish you all the best in life. And same here, Dr. Qadri, you're doing already well. Ravi Chandra, you're a seasoned guy. And also thank the president, Dr. Narender, for allowing us to participate, have this platform. Have I missed anybody, Vijay? Please add in. Talk to the vendors as well as Dr. Vipul, Cipla for...
Vipul, Vinod, okay, the technical team, Puneet, okay, they are all always stand tall behind us and facilitate these webinars. Okay, very smooth to run it very smoothly. And more importantly, Nasser sir, okay, phenomenal moderation. Thank you so much for accepting. Really,
and,
okay.
The kind of questions he brought to us, small things from the surgeon's point of view. I mean, he has done a brilliant job of, making surgeons walk back into malignant pleural effusion. So think of it.
Thank
you so much, sir. Thank you.
You're amazing. You're amazing.
Goodbye. Stay safe. Take care. Bye then.
Thank you, sir.
Thank you.
Thank you.